Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Riley. Peace, peace. Welcome, YouTube. We pick up in the 32nd chapter. Like I said before, there's only 34 chapters in this book. We did it again. We're about to complete another book. So, gratitude, highest heart, love, and honor. Thank you for being here, reading books with us, and being in this peaceful part of YouTube where we read books and learn from masters. So, we pick up at page 475 in the middle. All right, here we go. CO2 retention in COPD. There is no demonstrable correlation between the severity of COPD and CO2 retention. It appears that numerous factors are involved, few of them well understood. Central nervous system response to increased carbon dioxide blood levels is complex and variable. Some obese patients have decreased response capability, Pickwickian syndrome, as do some non-obese individuals, primary alveolar hypoventilation syndrome. Recent investigations into these responses during sleep and within families, i.e., genetic factors, have raised fascinating questions, but as yet no answers. Although these matters are of great intellectual interest and deserve intensive investigation, the respiratory care practitioner needs a practical, comprehensible, and clinically applicable schema into which clinical realities may be set and which may provide a foundation for future knowledge. The following theoretic and teleologic discussion is illustrated in such a schema. Figure 32.2. It assumes that cardiac reserves diminish in a progressive manner with time, but the heart maintains a cardiac output adequate to meet metabolic demands in terms of tissue oxygenation. As depicted in Figure 32.2, the early disease process results in progressive arterial hypoxemia, secondary to ventilation perfusion deterioration. Point A. When arterial oxygen tension reaches some minimal level, usually around 60 millimeters Hg, the peripheral chemoreceptors experience decreased tissue oxygen supply and respond to stimulating both the ventilatory muscles and the myocardium. This stimulation produces the amount of myocardial and ventilatory work necessary to maintain the arterial oxygen tension at a level minimizing chemoreceptor tissue hypoxemia. Peace, highest heart, love, welcome. Thank you for being in this peaceful part of YouTube where we read books and learn from masters. So, highest heart, love. Thank you so much for being here. God bless. Happy Sunday. Divine Rising. All right, this is 32.2, a theory on the pathogenesis of ventilatory failure in chronic obstructive pulmonary disease. A. Decreasing arterial PO2 due to early disease process. B. Peripheral chemoreceptor stimulation begins and becomes a primary drive to breath. C. Arterial PO2 level remains fairly constant, whereas arterial PCO2 level may decrease to some degree. D. theoretic points at which work of breathing is so costly that a decreased arterial PO2 is unavoidable. See text. E. Arterial PO2 begins to decrease and arterial PCO2 begins to increase. From Shapiro, B.A., Harrison, R.A., and Walton, J.R., Clinical Application of Blood Gases, second edition, Chicago Yearbook Medical Publishers, 1977. So here we go. At the top, you'll see the CO2 central mechanism is 100 millimeters Hg, and then it goes to 80 millimeters Hg, then to 60 millimeters Hg, and then 40 millimeters Hg, all the way to 20 millimeters Hg. And then you see the peripheral chemoreceptor hypoxic mechanism. And down at the bottom is the time and progressive disease. You'll see where they interact in the dark shaded bar and how they stay parallel in the peripheral chemoreceptor area. Here we go. 40, page 46 at the top. Thank you so much for the likes and subs. We're pushing towards 600 subscribers on this peaceful part of YouTube where we read books and learn from masters. So this is Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And we are almost finished with this book. Another book completed on this channel. We are the champions. All right, so it says maintaining the arterial oxygen tension at a level where the peripheral chemoreceptors are minimally stimulated in the face of progressive disease necessitates increasing ventilatory and myocardial work. The increasing ventilatory work is reflected in figure 32.2 by somewhat decreasing arterial carbon dioxide tension at point C. The increased ventilatory and myocardial work continues to maintain the minimal arterial oxygen tension that satisfies the chemoreceptors. Point D will be reached when the work of breathing uses so much oxygen that increasing total ventilation actually consumes more oxygen than is gained. In other words, physiologic dead space is so great, shunting is so significant, and the work of breathing is so inefficient that a further increase in alveolar ventilation, seldom below 35 millimeters Hg, produces a net loss in arterial oxygen tension. It is essential to understand that at point D, the organism faces a decrease in arterial oxygen tension, whether ventilation is unchanged, increased, or decreased for the following reasons. 1. Unchanged alveolar ventilation leads to decreased arterial PO2 because of increasing shunt and shunt effect. 2. Increased alveolar ventilation requires a great increase in ventilatory muscle work because the wasted ventilation, physiologic dead space, is larger. In addition, the vital capacity is decreased and airway resistance is increased. These factors lead to an oxygen consumption for increased ventilatory work that is greater than the oxygen gain from the increased alveolar ventilation, i.e., a decrease in mixed venous oxygen or PO2. And 3, decreased alveolar ventilation decreases the oxygen consumed for the work of breathing. But this oxygen gain is not great enough to offset the oxygen loss from the decreased alveolar ventilation. The organism obviously chooses the alternative that results in the smallest arterial oxygen loss for the last energy expended. As shown at points E in figure 32.2, alveolar ventilation slowly decreases as arterial PO2 slowly decreases. The cardiopulmonary homeostatic mechanisms dictate that The organism decreases effective ventilation and adjusts to the hypoxemia. It should be recalled that the organism chooses a ventilatory pattern according to work efficiency rather than ventilator efficiency. See Chapter 3. Peace, everyone. Thank you so much. Oh my goodness, random anime nerd. Highest heart love. Thank you so much for being here. Highest heart love. Said, bro, you are heavenly. Thank you so much. God bless you too. Much love to all the book readers and the book lovers community. Live from the light here in LA. You're reading books for free, thousands of dollars information for free. And it's a service that I love to be able to provide to you. So thank you so much for being here and subbing. Clinical course of chronic obstructive pulmonary disease. The respiratory care practitioner's difficulty in understanding the severe COPD patient stems from a hesitancy to accept two essential facts. One, the COPD patient's baseline state varies from the normal population. This means that a chronic CO2 retainer must be evaluated from his or her own baseline state rather than from the normal PCO2 of 40 millimeters Hg. And two, symptomatology and disability cannot be evaluated in the usual terms of acute medicine. A broad definition of disability is a significant limitation in the ability to perform common or essential tasks. A patient with pulmonary disability is one who is unable to perform activities of daily living because of pulmonary limitations. A COPD patient manifests pulmonary disability for the following reasons. One, the progressive pathology results in increasing disparity between ventilation and perfusion. This leads to increased work of breathing, decreased arterial oxygenation, and increased work of the heart. Two, emphysema, chronic bronchitis, and asthma cause congestion of the pulmonary mucosa as well as dried, retained secretions. These factors lead to increased work of breathing, uneven distribution of ventilation, decreased arterial oxygenation, and increased myocardial work. And three, the patient attempts to avoid physical activity that participates in shortness of breath or other discomfort. This limitation of activity produces lazy muscles that require more oxygen to do less work. And this increased oxygen requirement results in further limitation of activity. Four, the psychologic and emotional overlay is profound. The patient becomes depressed and believes there is no hope. And five, failure of the right and left heart, as well as other non pulmonary diseases, may compound the symptom complex. The COPD patient is a chronically ill individual with overwhelming physical and emotional symptoms, is always hypoxemic, and often is a carbon dioxide retainer. His or her exercise tolerance is diminished, and he or she depends primarily upon his or her cardiac reserve to maintain homeostasis. He or she lives in a hostile environment where he or she is threatened in his or her ability to perform ordinary activities of daily living. This may lead to a state of depression that becomes overwhelming. These individuals are often cantankerous, and for they have been shuttled from doctor to doctor and from institution to institution, and this has led to a great frustration. They do not do not trust the doctors and are usually distrustful of therapists and nurses. Above all, they are individuals who are hesitant and unwilling to accept their chronic disease. The respiratory care practitioner comes in contact with this patient in two circumstances. One, when the patient becomes acutely ill and enters the hospital. And two, in the setting of pulmonary rehabilitation. All right. Middle of page 478 for those in the playlist and reading along. Acute care of chronic obstructive pulmonary disease. It is common for the respiratory care practitioner to be confronted with the COPD patient who has an acute decompensation of cardiopulmonary homeostasis. This decompensation is most commonly due to acute pulmonary infection, atelectasis, bronchospasm, or heart failure. In any case, the respiratory care supportive needs fall into two categories. One, maintenance of adequate bronchial hygiene, and two, judicious oxygen therapy, aggressive bronchial hygiene therapy. The COPD patient has a chronically decreased ability to maintain adequate pulmonary hygiene, and therefore retention of secretions is almost certain when an acute insult occurs. Aerosol, IPPB, and chest physical therapy techniques should be used in an attempt to promote and maintain optimal bronchial hygiene. See Section 3. Obviously, good systemic hydration is essential. The air is important in acute care of the COPD patient. Tracheostomy is usually not necessary, since the placement of a nasal tracheal tube is generally adequate for short term needs. Optimal bronchial hygiene may necessitate intubation. Under these circumstances, the risk of airway contamination are worth taking. Remember, it is for the purpose of aspirating the trachea and providing adequate airway care that the endotracheal tube is often indicated. Intubation should not be performed on the basis of ventilator support alone. Quantitation of the effectiveness of bronchial hygiene therapy is frustrating and difficult in these patients. However, when these patients are deteriorating due to retained secretions, the general improvement in work of breathing, spirometry, and arterial blood gases is obvious and impressive to any observer. It is essential to serially measure arterial blood gases to assure maintenance of baseline PCO2 and to avoid severe acidemia below 7.20. Cardiac and circulatory status must be clinically evaluated. Middle of page 479. Oxygen therapy. The schema in figure 32.2 clearly demonstrates that maintenance of tissue oxygenation is the primary determinant of ventilatory effort in the CO2 retainer. Thus, these patients provide an unusual circumstance, the ability to manipulate ventilatory and acid base status with varying inspired oxygen concentrations. In addition to this built in hypoxic drive mechanism, all COPD patients have very poor distribution of ventilation and therefore have a great degree of shunt effect, i.e., alveolar oxygen tension will change significantly with small variations in FiO2. See chapter 7. The primary, the prime cardiopulmonary homeostatic response to increased alveolar oxygen tensions will be decreases in ventilatory and cardiac work, not changes in arterial PO2. The respiratory care practitioner must understand the nuance and sophistications of oxygen therapy for these patients. In the acutely ill patient, the need for high flow oxygen systems, see Chapter 7, is common. Often, it is an inappropriate oxygen apparatus that causes severe problems. Remember, the acutely ill COPD patient is breathing rapidly and shallowly. Therefore, small tidal volumes exist in which low flow delivery systems are often unpredictable and inconsistent. Chronic hypercarbia. Chronic hypercarbia, secondary to COPD, is the classic picture of respiratory failure patient. The PaCO2 is above 50 millimeters Hg, and the PaO2 is below 50 millimeters Hg when the patient is breathing room air. These patients have adjusted to an inadequate alveolar ventilation and low PaO2. They depend upon the heart's ability to maintain an adequate cardiac output, even though the cardiac reserves are limited. The drive to breathe is primarily from oxygen chemoreceptor stimulation. This patient is in precarious homeostatic balance. A typical example is a 70-year-old man with COPD and chronic hypercarbia. In his baseline state, without any acute distress, his vital signs and arterial blood gases are pH 7.43, PCO2 65 millimeters Hg, PO2 43 millimeters Hg, BP 160 over 120, P 110 per minute, RR per minute, and VT 30 milliliters, MV 9 liters. It should be noted that the patient has a pH greater than 7.40. This is typical and is believed to be due to water and chloride ion shifts between the intracellular and extracellular spaces occurring as part of the metabolic compensation for the respiratory acidemia. It must be remembered that this patient breathes primarily in response to chemoreceptor stimuli, mhm, and only hard enough to retain his baseline hypoxemic state. Administering 40% oxygen to this patient will result in a profound decrease in the demand for ventilation, i.e., the increased alveolar oxygen tension allows the usual arterial oxygen tension to be maintained at even less alveolar ventilation than before oxygen was administered. The organism will elect to breathe less hard rather than overwhelmingly increase the PaO2. This results in an acute decrease in alveolar ventilation, increased PaCO2, and acidemia. The vital signs and blood gases of this patient on 40% oxygen may be pH 7.20, PCO2 90 millimeters Hg, PO2 is 60 millimeters Hg, BP is 20 over 40, P is 140 over a minute, and RR 45 a minute, very shallow, VT 200 milliliters, and MV 9 liters. Oxygen therapy has produced an acute respiratory acidosis. This acute decrease in alveolar ventilation is superimposed on the chronic hypercarbic state. Despite improved arterial oxygen tensions, the acute acidemia and general CNS obtundation now threaten tissue oxygenation to a greater degree than did the pre existing hypoxemia. The primary effect of oxygen therapy in a patient with chronic hypercarbia may be the change in ventilatory status. This is not true in acute ventilatory failure, acute respiratory acidosis, or in other conditions in which the drive to breathe is not chemoreceptor stimulation from hypoxemia. Much confusion and misinformation exists concerning the application of low concentrations of oxygen to support respiratory failure. A clear understanding of the pathophysiology and pathogenesis of chronic hypercarbia makes the clinical application of oxygen predictable and understandable in its supportive role. Remember, oxygen therapy is never a cure. Proper application of oxygen will, one hopes, support the patient's cardiopulmonary system by improving the ventilatory status as well as the oxygenation status. And we'll pause right here. Top of page 481. Woo! Of chapter 32. So, when we reconvene, chapter 7, 32, we will pick back up in page 481. Right. We are coming around. Coming around. Thank you so much for reading with us. Highest heart, love, and honor. Thank you so much for the likes and subs, all the book lovers community, all my friends and family. Highest heart, love, and honor. We're doing it. We're about to complete another book and a few reads. So thank you so much for being here. Thank you for all of you honoring the book lovers community, all your friends, family, honoring our family and our loved ones that have elevated. We love you so much. We're about to sing you I love you to all our friends and family. Thank you so much for shaking it up on YouTube. Right here where we read books and learn from masters. I'm a master fitness trainer, Uriel Riley. So thank you so much. Woo! Hey. I love you so much, man. All the book lovers and readers and writers, I love you dearly. I'm going to publish this new book, all right? We're finished reading this. When we're completed with clinical application of respiratory care, we'll put out the harmonic vibrational. Yes. We're coming around. Yes. Thank you so much. Love you. I love you, Dad, Mom, brothers, sisters, Isis, my daughter. I love you, baby bubbles. Highest heart love. Y'all have a wonderful day. Time to drink some love water, right? Love you. I love you. I love you. I love you. That is the truth. I wish you had a wonderful day. I wish the reading went well. And I will put the vocabulary in the description when it's finished and complete uploading. Thank you so much. Highest heart, love, and honor. Bless you all as well. Thank you so much. All blessings. Blessings are coming to us. So grateful and thankful for all I have now and all that is coming to me. So grateful. Thankful. I love you. I love you. wonderful Sunday. Happy football day. We have another Your Healing session coming up. Heal the people. Right? That's right. That's what Yeshua would do. Healing the people every day. Eyes, heart, love. I'll see you soon. Peace, peace.